Hello and welcome back to our channel, where we help educate patients on effective, minimally invasive treatment alternatives to major surgery for conditions like arthritis, joint pain, uterine fibroids, hemorrhoids, and enlarged prostates. In this video, we're following a patient's entire journey, from chronic debilitating shoulder pain to a remarkable treatment that offers new hope. We'll take you behind the scenes into our radiology suite to see exactly how an innovative procedure called shoulder embolization is performed for our patient Jeff, who has graciously allowed us to film his entire procedure. But first, let's give you a little background on shoulder pain. For many people, chronic pain is a daily reality. For those suffering from debilitating shoulder pain caused by arthritis, adhesive capsulitis, what most people know of as frozen shoulder syndrome, and rotator cuff problems like tendonopathy, it can feel like there's no escape. So this was the reality for Jeff. He had suffered from chronic shoulder pain for over a year and tried numerous treatments, including physical therapy, arosty, PRP, and steroid injections. Because he didn't have an obvious tendon or cartilage tear, his orthopedic surgeon felt like he wasn't the best candidate for surgery, leaving him only to believe that his only choice was to just live with the pain. But there is another path, an innovative procedure called shoulder embolization that's changing the game. What most people don't realize is that a lot of chronic shoulder pain isn't just a mechanical issue, it's an inflammation issue. And in conditions like arthritis, frozen shoulder syndrome, or rotator cuff tendinopathies, the body can create a web of tiny abnormal blood vessels called angiogenesis that constantly feed the joint inflammation and pain. The best way to think about this, it's like a fire. Those abnormal vessels are the fuel lines keeping the fire raging, keeping the patient inflamed and keeping them hurting. Shoulder embolization is a minimally invasive outpatient procedure that offers another path other than surgery by getting in there and shutting down those fuel supplies. In this video, we're taking you behind the scenes with Dr. Preston Smith, a board-certified vascular and interventional radiologist, to see exactly how this procedure works for Jeff. Make sure you watch all the way through the end, as Dr. Smith will explain each step of the procedure as it happens, showing you exactly what he is seeing and exactly what he's doing. This will help any prospective patients who are considering this treatment to understand more about how it works and what to expect during the entire process. Thanks for watching, and we'll see you in the next video.
Are you comfortable, Jeff?
Yeah.
All right, perfect. Once we start taking pictures, it's just good for you to be in a good spot. So there is a thoracoacromial here. There's a suprascapular that's way up there, kind of outside our field of view. And then there's a coracoid, there's anterior and posterior circumflex humerals. So those are all the ones that I see kind of headed towards the joint. So there's one going there, one going there, and one there, one going there. And then there's a little bit of something that's off the screen kind of coming in. All right, did the micro. So we have this, just a smaller tube. It's going to go inside our bigger tube. So this is a micro catheter. We call this, just a 035 catheter. And this one has, this micro catheter holds, instead of 0.35 inch wires, it will, it's better suited to accommodate really small wires. So then we'll put curves on these wires to kind of help us get into some of the arteries. So a lot of the times we're kind of doubling back on ourselves. So for this situation, we'll start with kind of a gentle 90 or almost 90 degree curve. And then if we need more, we can make more, but it's kind of like a haircut. You want to start with a smaller curve, and then if it's not enough, start getting more aggressive with how much I'm curving it. Sometimes it can be hard to undo the curves a little bit. All right, so it seems that we have already found our way into something. All right, well, we'll take a picture. Quick puff of contrast, see where we are, make sure things look okay. All right, so you can see there's a nice acromial branch there going up to the acromion, and there's a lot of enhancement there. So
That's the bad part. That's the bad part.
yeah. Let's take a picture. This should get a acromial portion of that. Good. All right. So we can embolize with here. We're going to use that antibiotic slurry.
the anaconda.
The imipenum. Okay, that was about half a milliliter. Giving you there you go, some saline. Yeah, it's all right. Push that in with saline, clear the catheter. So it seems strange to inject antibiotics, but the guy who invented this has published a lot on it. And what happens is when you agitate and kind of quickly inject back and forth in a three-way the antibiotics, they form crystals that are a little less than 1/10 of a millimeter in size. And they're temporary, so it's especially good for the shoulder where a lot of the arteries that supply the shoulder also supply a lot of non-joint arteries. So, injecting a permanent sphere into, let's say the deltoid muscle or other muscles in the rotator cuff, it's not desirable. So the antibiotics are a great choice for this area. There's some other liquid agents too that can be used. But this is the original flavor of joint embolization. So we've got the most data on imipenum slurry. All right, so take a picture once we've done the embolization. A lot less enhancement. So that's nice. Okay.
Which artery are you in?
We were in the thoracoacromial.
And good.
All right. Take the wire back. I'll get my road map back over here. You can pull that out. This is contrastless saline. All right, so that's another really good artery that we're gonna have to inject. This is the suprascapular. It's a little further off here, but it goes through. There's a scapular notch that is basically right in here that it goes through. So you can see there's branches that are kind of going to the top part of the scapula, as well as the acromioclavicular joint too. All right, well that's nice. We can embolize from here using the the slurry. So that's great. We've got slower flow. Most of that enhancement's all gone, so perfect. We got two of the most important arteries. The guy who invented this is Japanese, and he didn't even really talk about the names of the arteries. He just numbered them, like 1 through 8. And he would say 2 is really important. And he was talking about the thoracoacromial, and he said 1 is sometimes important, but he's like, you really got to get 2. So it's always good when we easily can get into the important one first. We have a tube within a tube and then a wire behind it. That's the basic setup. The larger tube this all runs through, the reason that we need it is because we have to inject dye, and you just need a wider tube to inject dye from. And you need to get enough volume of dye to fill all of the arteries that you're interested in. So you can't just drip a little bit of dye. You have to quickly inject a lot of it. So we have this base catheter, and then through it we put this much smaller catheter. And that catheter is small enough to be able to get into these arteries without aggravating. And it can also move a lot further since it's not as stiff as the bigger ones. It's a lot like plumbing, you can only get so far out in the pipes before you just don't have any ability to kind of push your tubes out any further. These small tubes, and this larger one as well, they all have angles on them. So they're either straight or shaped with a hockey stick angle, sometimes a curved angle, sometimes a double curve. I can't really do that with my hand, but sort of a swan neck appearance. And all those are useful for kind of getting into these different arteries, because the arteries don't come off at just sort of right angles. They sometimes come off and double back on themselves, so like a hairpin turn on a racetrack or a 180-degree turn. So you have to think about all these things. And so between this angle, the smaller catheter angle, and then the shape we put on the wire, you can kind of create a nice base and then set of shapes to get through into all of these arteries, and then sometimes get past a bunch of stuff that you don't want to embolize. So that's the reasoning behind this kind of multi-catheter catheter wire setup. You can see that there's some enhancement. You can see the head of his humerus, so that's the thing about that is like the shoulder joint. There's some arteries that go over there and light up or stain the shoulder joint right here. So those we want to target. Now, it's difficult to actually get our tube through this rat's nest right here and figure out every single artery going to there. And, you know, honestly, it's not, you may end up missing some of the arteries that supply it if you find one and you think you've found them all. So having something to embolize that can safely be used to embolize some of this shoulder over here, but also hit the arteries that you want to hit, is good. So that's why another reason why we use the antibiotic slurry for this indication. You know, we used to just use beads in the past, but you'd get to places like this and I'd have to get my catheter just into a couple of them. Sometimes I wouldn't be able to find every single branch that was, you know, perfusing that. There we can see these arteries that we were trying to target lighting up. So it's good. So we talk about this being a new and, you know, groundbreaking procedure, but it's been done outside of the States for a decade now, and this has been used safely. Let's look back here and see if we can find the other circumflex humeral. Look at that, there's another branch going to the shoulder. I mean, that's really clearly going to the shoulder, okay. It looks like it probably would have been a branch coming off of that same circumflex we were in, only it just, right when it came off, this smaller second branch originated. All right, so we'll take some, and swish me up some antibiotic sludge. Sometimes I'll just wait until I see it come out of the catheter. There you go. And then we'll just, so the catheter's full. Usually these catheters will have a little less than half a milliliter in them. So if you just fill up the catheter, you know you're gonna end up embolizing with about half a milliliter, which should be plenty for this area. Oh yeah, that's a pretty picture. Let me snap a picture of it real quick.
You filming all this?
Yeah. Oh, this one will go in the, I just wanted to take an x-ray of it. We can catch it if it slowly fills the joint space. I mean, that looks pretty. That's just like perfect. Yeah, that looks good. That's a better picture.
Is that for joint space?
It's like it's basically this whole area, you know, but that one's just going right up the humeral head to like the metadiaphysis, or you can think of that as like where the neck widens out. Let's see if we can find this other artery we're looking for.
It was probably getting close to.
We are getting close. All right, so this is far enough in there for us to at least inject this and see where it's going. People always ask, do you embolize every single thing that you get into? And the answer is no. You know, I think it should be obviously no, but take a little bit better look. I'm not seeing a lot of shoulder enhancement there. Okay. So now let's just look at before we call it a day, let's go back and look at this very first picture we took. It's a nice exercise just to make sure there's nothing that I was thinking about. When you do the injection, you just want to make sure the single artery that you see kind of going towards the shoulder, you've at least injected. All right, so 1, 2, 3, and then we just looked at this one. Let me go back over here and make sure. Yeah, that's okay. So we got the one that's coming across. Okay, so we're done. So again, we don't embolize every single artery, but we look at all of them that are going towards the shoulder and use whatever embolic agent kind of makes sense. We usually use the antibiotic slurry for the shoulders with all the non-target embolization. All right, so now this is the easier part.
I can feel something in my bicep. Is that normal?
Yeah, you're having your arteries spasming a little bit, so we're slowly gonna take this out over a wire. Arteries are like, I guess they're sea cucumbers or sea urchins or sea something. When you bump into them, they kind of clamp up. So we can inject some nitro through this. Having a catheter usually helps out a lot. There we go, see it? Or having a wire, in there helps out a lot. Yeah. All right, and then to pull this out, we'll clean you up first, but we're going to put a bandage on it. Any of these procedures we're doing from the wrist, there's no stitch or anything that goes into it. It's just a band that holds pressure on this little hole that we made with our sheath. This is called a sheath. I usually refer to it as an entry-exit port because I think patients understand what that is a little better. The only sheath that I know of that people think about is a sheath to a knife. So I don't think it's a very useful way to explain. I'm like, a sheath, and people are like, I have no idea what that doesn't. The sheath goes in my artery. That doesn't make any sense. So, all right, we'll clean you up first. That looks good. All right, now I gotta look at these directions every time. You got the thumb on this side. Oh, there we go. They make it easy for you. All right, I'm gonna lift your hand here just a bit. And so they even have this little bullseye where you go in, even though we see our stubs go into the skin there, the needle we get in with is actually a little towards the body. So I like to go in just on the edge of that. And then get this reasonably tight. We can pull out this thing that's kind of bending it. The first one of these it came out with suggested that we inject 17 milliliters of air. So then we'll pull this out. All right, so that looks good. And then we are going to slowly release air from the band. That looks good. You can feel his pulse here. Feels great. Don't see any bleeding, so that looks good. We're done.
That's right. That's where they went in right here. Went all the way up into through the arteries. I'm pretty wild. Go do some push-ups and practice my golf swing.
Exactly.